And if you measure that using a pulse oximeter or a SATS monitor, it's called, which Dr. Ho mentioned in their meeting, you will see that with someone with COVID, they look a wee bit breathless, but their oxygen saturation is in their boots. And our first wave treatment was to give them more and more and more oxygen and then ventilate them. And that proved wrong. First, it's wasteful of oxygen, but the other thing, it didn't make any difference. What we need to do is stepwise increase the oxygen that we give them using just nasal cannulas, then a trauma mask, prone positioning of the patient, a CPAP mask, and the ventilation is at the very end of the spectrum of treatment with, as I said, very poor outcomes. Because patients with COVID seem to manage with very low oxygen saturations of 70, 80%, that is now acceptable. We don't keep turning up the oxygen to try and get 100%. And one of the big mistakes we made in the first wave, and I'm aware of is happening in areas that haven't been so well trained, is that people just turn up the oxygen to try and get that 100%. So it's very, very, very wasteful of oxygen. Oxygen concentrators can deliver 90 to 95% oxygen concentration. They can do it at a relatively high volume of delivery, especially the better models. And they also require the use of monitoring. So you need to have a SATS monitor of some sort, and you need all the tubing and all the pipes and the masks. And all of these are missing in Malawi. I mean, they're missing in the theatres and anesthetic rooms. And we need to, they're just reused, they're held together with tape. And I've got a presentation that I just put together this morning, but it's probably not too much to do just now. But it's quite scary how the consumables are missing. And then again, it was mentioned, and Ari mentioned this in his talk, power to maintain, to actually run these machines is intermittent. Load sharing means that you might only have power for 8 hours a day. Indicative costs, oxygen cylinders are incredibly expensive, they're heavy to transport, and people are talking about you have to check them and maintain them frequently. So that's an expense, but it's also time when the oxygen cylinders aren't being used. And the oxygen cylinders cost in the region of $200 to $300 each, a good oxygen cylinder from India. The British oxygen cylinders from BOC are even more expensive. An oxygen plant, probably if you're looking, we're looking at, for example, the one that the Levi in Zambia, $1.5 million, and it took 18 months to build. And that was supplied by an Indian company building with Chinese bits and pieces. And it's already broken down, which is one of the problems they have exactly at the moment in Zambia. One of the big problems is that the oxygen plants are not working at full capacity because of maintenance issues. Oxygen concentrators, variable in Malawi, Northern Malawi. Every working oxygen concentrator, there's probably 5 or 6 sitting that weren't working. Maintenance is a huge issue, and we highlighted that to the Scottish Government. But more importantly, the quality of the generators is very, very variable. So you can get a very good high quality generator, secondhand refurbished from Britain, about £250. They're quite heavy, so transport is an issue. They probably cost about $150 to send each one to Malawi. But these are available off the shelf today. And they could be in Malawi in 4 to 5 weeks, especially if the ministry facilitates their arrival. Because one of the problems is clearing them when they arrive in the long way, usually by air freight, because that's the quickest way of getting things there. A lot of the companies that will supply, such as MedAid International, work with the NGO sector all the time. Very, very good company. And they have a whole bunch of the consumables, and they can supply those as well. They usually supply those free of charge. And the last bit is the oxygen monitoring. Pulse oximeter, like Dr. Ho mentioned, £25, £30. The problem is that they are small and they're easily mislaid. People like them, they take them home with them, and then they forget to bring them back. And need a little battery, but they work very well. They're very good off the cuff. bigger oxygen monitors, such as life boxes and equivalent, with probes about $250 to $300. So you're looking for one supply of oxygen, you're looking at the best part of $600, £600. And last but not least, that's worth mentioning, is maintaining them is going to be a big issue. And then the supply, the power supply that both Ari mentioned, but also was mentioned in some of the paperwork you sent out, some of the concerns we have. Generators are the quickest way of getting things up and running. Small 9 kilowatt kVA generators, which are about £300. But ideally, solar paneling is where we need to go. There are deployable solar panels, but I don't have that expertise, but that exists in Strathclyde, and I think one of those people is on the call today. That's really my thoughts. Thanks very much.
That's extremely helpful. Thank you very much. I wonder if that gives a neat segue to Edgar. I wonder if I can spring it on you, Edgar.
Maybe I was wondering if you could give me a chance before maybe anybody continues.
Okay.
Because I would like to, my name is Stanley. I'm a Malawian based in France. And currently I'm leading an effort at national level to fundraise and to respond quickly to COVID-19 in Malawi. I started with my colleagues, we launched the initiative on 15 January. We have been fundraising. This is the 18th day. We have raised close to $170,000. Now, here's what we've done. We have, Albert was talking about pulse oximeters. Just this morning, just before coming to this meeting, 3 minutes before coming to this meeting, I approved procurement of 300 pulse oximeters to be distributed to hospitals across the country. And then we bought 40 oxygen cylinders, 40 pressure regulators, because they are also a problem. And we filled those 40 oxygen cylinders with oxygen. This is money coming from very poor Malawians, from their pocket, from primary school kids at Area 2 in Lilongwe, from a guy who sold his car to contribute to our initiative, from secondary school teachers, primary school teachers, from the police, the army, from people in the street who spared their last coin and have entrusted my team and myself to try and respond. We call it corporate. We call it COVID response private citizens. COVID response private citizens. So we have raised about $170,000, and today probably we'll hit $190,000 because somebody has promised us $12,000 somewhere, and my team is going to collect this check this afternoon in Lilongwe. So our understanding of the oxygen crisis in Malawi, because this is what made us dive into this. We said, okay, look, the government is trying its best. It's trying to organize itself, get some funds and all that. The systems have been overwhelmed. I personally was moved because a friend of mine in college died because of lack of a pressure regulator, of a flow meter at Kamu Central Hospital in Lilongwe. And so he couldn't have oxygen, and then he died. So then we moved into this and said, okay, fine. Let's try to raise funds. Our analysis, understanding of the situation, as Alberto has correctly put it, number one, the issue of oxygen in Malawi, currently, there aren't enough cylinders. Now, Alberto has clearly explained that, okay, what is maybe concentrators, cylinders, the dynamics and all that. In Malawi, like Alberto said, the issue of electricity is a big issue. So the good thing with a cylinder is that you can still administer the oxygen without the electricity. Concentrators, another friend died at Partners in Hope in Lilongwe because the power failed and he was on a concentrator and he died crying for oxygen, you know? So because of power failure in Malawi, the problems that are around power, cylinders have proved to be quite effective, but at the same time, a good combination of cylinders and concentrators would be the best way to go, because I mean, Alberto has done a great job explaining the advantages of concentrators, and he has also brought in an angle of how maybe some power generators can come in to support those cylinders in the event of power failure. we found 32 concentrators that are disused in the storeroom of the Kamuzu Central Hospital. My team found that. And we are trying to rescue these. By yesterday, we had 8 of them repaired, and we want to distribute them to citizens, to hospitals across the country. There is a team of young Malawian men and women called the Global Health Informatics Institute in Area 3 in Lilongwe, who are dedicated. They are providing their services to us for free to repair this. The challenge we are facing for the remaining 24 cylinders that they are working on is that there's a need for zeolite granules. So with my colleagues, we are trying to import these zeolite granules from China. My board will be approving this today to see if we could bring in maybe 2 or 3 kilograms of zeolite granules. 1 kilogram costs $1,280. So we feel that if we can rescue these 32 concentrators, perhaps maybe they could make a difference. There are 3 oxygen plants in Malawi. There are 4 basically. So the first one is at Queen Elizabeth Central Hospital. The second one is at Kamuzu Central Hospital in Lilongwe. These plants, let me just explain about these first 2. They were installed by a company called Intercatek based in Cape Town in South Africa, and they're the ones who maintain it. And the one in Lilongwe broke down on 16 January, but it has now been maintained by Intercatek and it's up and running. There's another one at Nkata Bay in the north. Then there's another one at Palombe. The Palombe one, there was a funny story because when I was chatting with the Minister of Health 4 days ago, she lamented the fact that although it's a brand new small plant, people were not using it because they were waiting for her to commission it. So officials in her own ministry said, okay, no, we can't start using this oxygen plant because the minister hasn't come to cut the red tape. So then she blasted them and said, look, what we need is to save lives. Go and start using this one. So we have these 4 plants, but the 2 plants, the one in Nkata Bay and the one in Palombe, they are small. Even the one that is at Kamuzu Central Hospital, which has now been piped into the wards, it's not adequate for the. It has also got some points for cylinder for filling in cylinders, apart from being piped into the wards. In any event, it can only fill up to 48 cylinders a day. The needs of oxygen for Kamuzu Central Hospital alone are about 210 cylinders in a single day. So the same applies to the Queen Elizabeth Central Hospital. The plant there doesn't, its input is not enough. Its output rather is not enough to suffice or to provide for the caseload or that is there that is being managed at present. So then the one at Nkata Bay is even smaller. So the north is, every day I think about the north because it's a bit of, you see, geographically it's a bit far flung. Normally people like to describe our country that it's a small country, but it's small in relation to what? The size of Malawi is 118,000 square kilometers. You can put Netherlands, Switzerland, and Belgium into it, throw in San Marino, Andorra, the Vatican, and everyone. So it's small only in relation to other countries. I don't know, but around it's a big country. So the north alone is so geographically spread that somebody in Chitipa wanting oxygen would have, as we speak, to travel all the way to Lilongwe to get oxygen. I've been thinking that perhaps if we could have some kind of plant in Karonga that caters for Chitipa and Karonga at least. So because those are the remotest districts from everywhere. At least Rumpi is in the middle. It could go to Mzuzu, where Afrox has got some kind of plant that some kind of depot that provides oxygen. Afrox itself is getting overwhelmed. They have created a scenario in which they say they cannot accept any other cylinders from anyone other than from themselves. So the government has got, as we speak, at Kamuzu Central Hospital, it has got 200 brand new cylinders which were bought during the first wave, which Afrox is refusing to use based on some, like they can disqualify a cylinder based on anything. Yet they have run out of capacity to supply cylinders themselves. What they are doing now as we speak, they are repurposing oxygen, industrial oxygen cylinders from breweries and other places to try and repurpose them into medical oxygen cylinders. But at the same time, they're still refusing to accept filling any other cylinder. So we've had behind the scenes discussions with the minister to say, look, please, we're now in a state of war. And if because the same cylinders, Kamuzu Central Hospital is able to fill them with oxygen, and they're working just fine. There's another small plant by a certain guy in Nilongwe of oxygen. They go fill in those cylinders are working just fine. Yet Afrox is refusing to fill them. But the areas they themselves can supply cylinders to Malawi is probably 6 months from now, because they don't manufacture them in South Africa, they are manufactured in India. And the manufacturer in India has got a long queue. And so the Malawi government keeps saying that it wants to order 1,000 cylinders. But for the life of me, I have no idea where they will get the cylinders, which should be acceptable to Afrox. So this means then we badly need concentrators, as Alberto said. We need concentrators, but those concentrators need to come with a power backup, because if the electricity fails, then they are no use. At the same time, as I said, we need some kind of oxygen plant. I've seen on, I've been checking on, I've been even thinking as an initiative whether we could buy one from China, because we've been checking on Alibaba, for example. It ranges from 15,000 to 50,000 US dollars. A sizable plant that could be put maybe in Karonga and make a difference. Why Karonga? Karonga is neighboring Tanzania, and the Tanzanian government has been very lax when it comes to corona. In fact, it's in denial. It says corona does not exist. So the caseloads from Tanzania are spilling over to Karonga, and the Karonga hospital gets overwhelmed as a result. Let me stop there. I don't want to consume all the time, but I thought I should weigh in and give you the situation from our point of view as the corporate citizens, COVID response private citizens. Thank you.
Stanley, thank you very much indeed. That was extremely useful and insightful. And I've been aware of your initiative and following your website, and all congratulations there. And I think a serious point for consideration for this group is whether we combine forces and work together. I'll come back to that question. I do want to come back to renewables, because I know there's been existing conversations. Edgar, Community Energy Malawi, you happy to say a few words from your perspective about priorities and opportunities on renewables? Edgar Biani.
Yeah, thank you very much. And before I continue, kudos to you, Stanley and Kenani. I think the private initiative, citizens initiative, has really made a huge difference. And I think I've even noted that our class in college, we're even mobilizing resources just to make sure that we pump into that initiative. That's what we need, reading from the front as citizens. Yeah, so just as Stanley has just said here, I think as Community Energy Malawi, we are moved to start looking into this issue, especially after reports of Mr. Hanja and another colleague passed on at Partners in Hope, a private hospital. You know, at that moment, I think the Central Hospital was overwhelmed, and some of the people went to Partners in Hope and other private hospitals to get treatment. But they died really crying that they are looking for oxygen after the power went off. So as of now, I think our situation as a country, it is very bleak in power supply. And when we went around the hospitals, we see that I think a 9 to 10 kilowatt system is required as a backup. And even if we say it shouldn't be a backup, but something that really should power all these what we call isolation centers, even though we prefer to call them COVID treatment centers, because isolation somehow psychologically paints something else, but they are COVID treatment centers, healing centers. Yeah, so in our case, really, we're looking into at least having some power backup for Queen Elizabeth Hospital, Kamuzu Central Hospital, and of course, this time around, the COVID field hospital has been moved to the Bingu National Stadium. So obviously, I think we have to look at the setting the power there, and of course, Mzuzu Central Hospital. And as Onjezan has said here, the power plant, the oxygen power plant in Hatabe 2 is one that is relying on ESCOM. Of course, in Hatabe has some solar systems installed, but then there is a challenge of maintenance. It seems as if in the Ministry of Health, to them, maintenance is about maintaining the hospital equipment, the beds, and all those other stuff. There isn't much focus on maintaining the power supply issues there. So you'd find that there are some solar systems installed on some hospitals, but some of them are not functioning. We've been to quite a number of district hospitals where probably other projects have pumped in some resources and installed some good systems, but a lot of them, they're not working now because there is a challenge of maintenance. So yeah, I think it would be nice to put our efforts together to make sure that we look at the oxygen supply, but at the same time, we also look at the power backup. I hope my colleague Damien, who is here from University of Strathclyde, is also going to add a few other things, because from the first wave, we were also looking at how best can we support the oxygen supply in the hospitals, because we noted that at that moment, people in the north had to travel all the way to Long. At least now they have got a COVID treatment center in Mzuzu, even though it's a few beds. I know St. John's Hospital has also established their own COVID treatment center. But I think all of them, when you look at the north and the population and the 10, 15 beds that are there, we still have to do a little bit more. And I think, Damien, you can please come in.
Go ahead, Damien.
Yeah, hi everybody. Thanks, Edgar. Well, I guess you've summed it up pretty well, Edgar. Really, the power supply situation is, as everybody knows, is pretty chronic. And you could put a sort of 10 kVA or something like that kind of value on the backup power supply required on the areas that we looked at. We had a small, just background, we got a small bit of funding from Strathclyde back in the summer to work with Community Energy Malawi and also Creative Energy in Edinburgh. Joel Cheney's on the call, I think, as well. Looking at oxygen concentrators and linking into a couple of international initiatives on open access for oxygen concentrators. And we worked with the Polytechnic, the design studio hosted in the Polytechnic, about local build of oxygen concentrators. But that's not an emergency response project. So it's not really, I don't think it's really relevant at the moment for this conversation. It's something that's got potential, I think, but it's not really about rapid mobilization of oxygen concentrators into remote and rural health centres in Malawi. Power supply, backup power supply, it kind of just depends, I guess, on what the circumstances of each health centre or each ward or the equipment that we're trying to power, obviously. So I don't think there's a single solution that's say, well, we'll just order loads of those. Also, importing solutions, there's plenty of companies, organisations, or whoever that would put together resilient power supplies, containerised solutions that could be entirely renewables, solar powered with storage, or it could be incorporated with some generators, or it could incorporate into a hybrid system that where there is a grid connection, integrates with that, so you utilise grid, storage and solar on site. However, getting the correct system for the particular circumstances of our location and getting it imported into Malawi rapidly is a challenge, I would say, and doing that in the right timescales. There are a lot of skilled engineers, and there is a supply chain for power systems and renewable power systems in Malawi that's pretty well established. So I think when we're looking at the power resilience aspect for certain locations, I don't know if Edgar, we need to have a think about how the skills in Malawi from the renewable energy industry, the engineering sector, coordinate well with the existing programs, just like that's been outlined by Stanley there, how we can support where there's activity on improving oxygen supplies, then how can we mobilise engineering resource to identify what the power resilience challenge is in priority locations, and then find the right people and get the right kit in place. I don't think there's a simple answer to say, let's just get hold of lots of these and ship them to Malawi.
Thank you very much.
But Strathclyde are active, working in Malawi with partners. There's a big resource, I think, of engineering skill sets in Malawi that could be harnessed. So we're ready to participate in supporting this initiative.
That's really useful. Thank you. I
wanted to. This is Anne.
Okay, very quickly, Dr. Poy. Dr. Lungu, who is the chair of the Mzuzu COVID-19 response team. So, Dr. Poy, over to you. What I'm looking now from everyone for the second half of this meeting is, as concisely as possible, what do you think Scotland, as a network, could be doing in this area? So I think we've got a really good sense of what the issue is there. But I'm looking for contributions that are concise contributions around what you think we should be using our network to do. I'll turn to Dr. Poyer first and then Dr. Lungu. Dr. Poyer, over to you.
Thank you, David. I just also wanted to check, because I know we have a number of broken concentrators in Malawi, and I'm sure the repair work may not require that much. So if we have a system in place that can assist the biomedical engineers in Malawi look at these concentrators, if they can be put back to work, they can be put in these small treatment centers. Over.
Absolutely. I think, looking at what are the easy and quick wins and rehabilitating cylinders, I think is key to that. Thank you, Dr. Poyer. Could I turn to Dr. Lungu? And am I right, Dr. Lungu, in thinking that you're the chair of the Mzuzu COVID-19 response team? Is that right?
Yeah, kind of. Yes, I was, and I still am, but a lot of things have moved on a bit. So just from just taking from the information that I've just gotten from here, Stanley, Alberto, Edgar, Damian, and I think most of what is being said is true. I come from the lower side of things, the frog, so to say. So for us in Mzuzu, at the very beginning of the first wave, it was very clear. We realized, I personally realized that we're gonna have a big problem. So we set up a treatment center right at the very beginning. When the COVID thing first wave hit us, it was clear that the government wasn't ready. Mzuzu Central Hospital didn't have a treatment center. They actually used my hospital to do the treatment for the first wave. And only towards the end, that's when they were able to move back into Mzuzu Central. We've been able to run a COVID treatment center based on oxygen concentrators. And the problem that we are talking about, and it's nice to have Ari around as well, because he's in the mission field. I work for MBF as well, which is the Medical Benevolence Fund, to help them to sort out, to help out with the mission hospitals. We do not set up systems where we are. So I've worked in every hospital I've worked in, the first thing I've said is we need power. So every hospital, I started working at the Kasungu District Hospital, worked also in Ekwendeni. The first thing was we need a generator. I worked with Deyang, we need a generator. And actually at Deyang, we needed both a generator and an oxygen plant. So we actually set up an oxygen plant at Deyang, because these things are quite important. Having said that, where can Scotland come in all this? I think we've run a treatment center purely out of oxygen concentrators. We can't afford cylinders because Mzuzu is not supplied with cylinders. We get about 15 cylinders a week from Afrox. They all go to come to Mzuzu Central. I've got one cylinder that gets filled every 2 weeks. It's just not possible to that. And I've been crying for an oxygen plant for the whole last year. We have a whole proposal. I think we're discussing with Suzanne about the same thing. I had a proposal up for that period of time for 5 hospitals to try and create a single oxygen plant and supply them with oxygen cylinders. But the problem is what Alberto is saying as well. Once you do this, you need to get a whole system in place. But with an oxygen concentrator, if we get the oxygen concentrators in place, there will be enough to support most of the patients that we can save. We actually divided our patients into those patients that can stay at home, those patients that need oxygen, and those patients that need ventilation. The ones who need ventilation, they go on palliative care. We don't do anything about it. We simply say, sorry, this is not something we can do. Now, the thing about oxygen concentrators is that we're talking about them about 15 years ago. This problem was addressed. What we did was to put oxygen concentrators with anesthetic training. So anesthetic clinical officer training includes maintenance of oxygen concentrators. All anesthetic clinical officers have been trained to maintain oxygen concentrators. And therefore, what we need is to try and support them to get so that they can continuously be able to maintain the oxygen concentrators on the ground in these hospitals where they are. And we can do that. And I think that kind of training will be much more useful than moving around huge amount of oxygen concentrators around to one place and to another place. But because most of the time, the oxygen concentrators, the problem is not so much that the granules are finished, is that they do not have a cable, or they do not have a humidifier, and so on and so forth. Those are the big issues. During the first wave, we also realized that most of the cylinders had oxygen, but they didn't have regulators. I ordered 25 regulators from Malaysia, I think it was Malaysia. At that time, a friend of mine from the US paid for it, and we shipped it. So from Zeus, we have regulators available. What we don't have are the cylinders now. So I would suggest that that's the first part, to just say, we're gonna make sure that every hospital has 5 oxygen concentrators that can work at any given time. And that's a commitment that we can make. The second thing is pulse oximeters. If you give oxygen and you can't know what you are giving and why you're giving it, makes no sense. And pulse oximeters can be brought in back within 3 weeks. I can get them within 3 weeks. And there'll be a lot of them, as Stanley has been saying. That can be done. The third thing is for the people who are using the oxygen pulse oximeters and the oxygen concentrators to know when to use oxygen. And that's also a big problem, because we have known oxygen as a drug that we give to people who are dying. You only give it when someone is dying. Because we have been doing that for years and years and years, there's a degree of reluctance among our nurses to use oxygen. It was the same thing when we were at Itayang. Once we had piped up the hospital, once the nurses realized that any patient coming out of theater, any patient who is sick needs oxygen, it became quite clear that it was helping very much. So we need to be able to train people to use oxygen. And training people to use oxygen is not that difficult. And one of the proposals that I was discussing with Suzanne has those 3 aspects to it. One, we need to do that. And I think the 4th aspect is, as we said already, is maintenance. So I would think that we need to base, as we are now, we need to base what we are doing on oxygen. And the idea that power is crucially important is a good that we have identified it. So we need to make sure that every place has a generator. Every place you go in Malawi that doesn't have electricity has a maize mill. These guys can maintain maize mills the whole year round. So it's not expertise that is in short supply. It's the generator itself that is in short supply, because it's just a diesel engine with a dynamo on the end of it. So we will be able to maintain a diesel engine. We can service it. There are people there available to be able to service it. There are very big trucks that you see in Malawi that people drive around that probably they stopped producing them in 10 years ago, and they're still running because there are people here who can make things work regardless of what what is on the ground. So we can do that. In terms of consumables, most of the hospitals, as Stanley was saying, most of the hospitals in their storeroom, they have got oxygen pipes. Oxygen, tubes, cannulas, nasal cannulas, masks, and so on. They just don't use them. They have them. It's a matter of going to find all these storerooms and be able to get them. And we get containers from Scotland quite often for the mission hospitals. And most of them, we just put them in the storeroom because we are waiting for someone to say, let's use this one, or let's use that one, let's use that. So there is the supply of most of these things available. So before I talk too much, that's my take on this.
Extremely useful. Thank you. Susan wants to come in. Susan, 2 minutes, over to you.
Muting myself. Thank you. I just wanted to share with the meeting that I've become involved.
Susan, I do apologise. You seem to have turned on to mute. Could you go back a sentence or two? Do apologise.
Yes, sorry. I'm Susan Flynn, and I've been involved in Malawi since 2005, but I do reside in the UK. I've got involved in this issue because of a contact in Blantyre. Mr. Bashir Osman is a very successful businessman who runs Adams Car Fleet, amongst other things. And he's Muslim, and he's very aware of some of the needs that have come through from the Muslim community, but he wants to take an initiative that will benefit the whole of Malawi, and he's prepared to put up, well, up to $1.5 million. But he would like the Malawi government to underwrite some of this, of course. The key thing is, what is the best way of using the funding? I mean, it doesn't have to be that amount, it can be less, obviously. And I've explained to him that this has to come through the Asian business community and not just through him as a person. So this would be there are Asian business communities in the major cities, but it is honestly for the whole of Malawi. And he's got a quotation for an oxygen plant from India that would produce 600 cylinders, and it's ready to ship. But, you know, we've been exploring the whole issue, and we're very mindful that we want to go, you know, the money's got to be used in the best possible way. And that's why I'm here today, to listen to you, to find out the best strategy to, you know, to use money effectively. Thanks.
Yeah, David, can I say something?
Yeah, go ahead, Dr. Poe.
Yeah, just in response to what Susan has said, I'm sure this Asian man lives in Malawi and he's listening to what is going on. I know that at the beginning of the second wave, the president, you know, went out to the public and invited everybody that has something to contribute to come to the National Task Force for COVID, so that they can put in their support. And I don't know why he's not using that mechanism, because I've been following on the radio private companies that have responded to the president's call. So if he doesn't know where to go to, probably I can give him my number. I can connect him to the people that are coordinating the national response.
No, he does know. He does know. He does
so
know.
why is he not going to that machinery? Because the government has created that system that if private companies, individuals that want to support the national response can go to that system. So why is he not going there?
He's in discussions with the Ministry of Health himself.
Okay, and the Ministry of Health has not given him a response on how to go about it?
No, not yet.
Because I'm asking this question because I know this afternoon the health cluster meets from 2 o'clock to about 4 to discuss issues, including issues of treatment. So I would like to understand what the issue is, so that when I'm in that meeting, I can raise this issue up. Or I can even call Dr. Mwansambo to ask him that this gentleman doesn't seem to be getting response that is necessary.
Can I jump?
Secondly, I wanted.
I'm sorry, Dr.
Secondly, I wanted to. I'm sorry, Dr. Yeah, just a minute, David. I wanted to. Yes, I wanted to just respond once to what Douglas has said about the concentrators, that there are so many of them in this country, including in Mzuzu. If Douglas went to the central hospital at the PAM unit, there are so many concentrators that I saw them myself a couple of months ago when I was doing training that hadn't been repaired. And the physical access people said they were not repaired because they didn't have the materials to repair them. So probably, Douglas, you can pay them a visit and see how many of them are there. Over.
Thank you very much, Dr. Poyer. I'm keen that we keep to everyone's keep to the time, finishing in 8 minutes or so, and I want to bring the meeting to a conclusion with a clear sense of next steps. What we can do as a network, and what is absolutely within our usual MO and comfort zone, is to continue to facilitate a regular space for this as a specific stakeholder group to share information about the specific question of oxygen supply in Malawi. And my assessment of the last hour is that that has been useful for people. I think there's been a really useful and sort of vibrant exchange of information, of contacts, both in the meeting and in the chat box as well. So that's something we as a network can very easily do if that's deemed useful for people. As often as this group wants, to be able to set an hour aside for sharing of information about the oxygen side. Secondly, we as a network can raise awareness of appeals that are already out there very, very easily alongside other appeals. And I'm really happy that we prioritize and push to the front those appeals around oxygen. So I would include not just those that are Scottish led, but Stanley's excellent private citizens initiative. Very happy to help promote that alongside others. My question, and I'd like to invite short, concise answers to this question now, is there more the Scotland-Malawi partnership as a network should be doing? Should we be rallying behind a specific and single cause? Should we be looking at any new initiative, or should we be identifying one existing initiative that we say, this is really what we want to push? We want to go and march in to see the UK government's Africa Foreign Minister and say, for God's sake, do this. We want to be putting pressure on the Scottish government and saying, do this. And it's that singularity of ask that makes it a more powerful and more likely to be successful advocacy. I can see Tom Hunt's hand up. So final contributions, those specific questions. Tom Hunt, over to you.
For what it's worth, I would do rapid research on what can have the biggest impact and try and collectively use your influence, David, to get behind one thing that has the biggest impact. Just briefly, I was at Kasungu District Hospital yesterday. No oxygen. A friend of mine, his family managed to get him one cylinder to keep him alive yesterday. So I won't go into all the details, but the situation is dire on the ground. So get behind one thing that can have the biggest impact would be my point.
Absolutely. I want to turn to Stanley, who put his hand up, and then Juliet. Stanley. Oh, sorry, Stanley, you're on mute at the moment.
Okay, can you hear me now?
Yeah.
Yes, quickly. There's a huge gap in testing. There's a need, as we speak, of 100,000 testing kits, and they cost, on average, 400 million kwacha. That's roughly about $500,000 US. Without testing and contact tracing and everything, we would just be treating people, be looking at the clinical side. That's number one. Number two, there's the oxygen issue that we have spoken about. I mean, everybody is fully aware of the oxygen. Number three, PPE. PPE, every hospital director that I've spoken to is talking about PPE, and we're spending 16 million kwacha this morning to try and buy some PPE and cover some gaps. So if we could just have these three things and have, you know, like a kind of develop a strategy of how we could respond, that would be awesome. Thank you.
Thank you, Stanley. Juliet, you had your hand up. Specific question of what the SNP, more than the coordinating and sharing information function, could and should do. Juliet, over to you.
Juliet is Hugh. Hi. Just a quick thing for me is that there are so many things that have been mentioned, and we know already on the ground, being here, that there is no ways that we will ever be able to reach out to everybody's requests, and therefore it is I think of significance that we need to refocus and decide where we're going to go. But without the right information, it's almost now impossible to decide on that unless we get the information of what everybody else is doing in the space. And there's enormous amount being done, either by government, by NGOs, by donors, by individuals, as can be already experienced on this chat. And it is quite incredible. But I think everybody's got their needs. And therefore, my suggestion would be if your group can get together and find out what is happening on the ground, who is doing what do we need to prioritize on, who can we partner with, so we can get our best bang for our buck as far as what needs to require. Because it's pointless following if somebody else is doing concentrators, for example. It's pointless us putting in another 20 concentrators if somebody put 120 concentrators in. So I think that coordination is essential going forward in whatever plans we're going to make and whatever priority needs to be done. Thank you.
Thank you very much. I have a question or an ask, and that is whether there is someone on this call with experience on the specifics, so technical expertise on this matter, with time over the next few months or so to volunteer themselves to help chair and lead this specific issue of oxygen supply. So someone that's able to volunteer, maybe an hour or two a day over the next few months to be able to help give the network the capacity to really drive this forwards. I think we've got a clear sense that there is real value in that coordination effort, in that sharing effort, in the raising awareness of existing appeals. But my ask is if there's anyone that would be willing to volunteer their time to chair this group going forwards as a sort of task-orientated group.
I volunteer for Stanley or Douglas. I volunteer for these two.
There's a fine tradition of volunteering other people. Well done, Edgar. I'm a big fan of it myself. So Edgar has heroically stepped forward to volunteer. I think that was Dr. Lungu, Douglas Lungu, and Stanley. Are either of you interested in taking that role on? I mean, Stanley, you obviously have a very successful campaign running at the moment, but you would be most welcome to if you wanted. Dr. Lungu, whether either of you wanted to come back on that proposal, or if anyone else wants to stand forward or nominate someone else.
Yeah, I think I'll be willing to give some advice on that. I'm not a total expert yet.
Okay, thank you, Dr. Lungu. Anyone else want to volunteer or nominate themselves? Alberto, I see a hand up.
Yeah, hi. I think coordination is important, and that's the one thing that keeps coming through. If anybody has worked in the sector on the ground, the lack of coordination on the ground is astounding, because there's so many people doing their own thing and often duplicating. So I think Douglas has got a lot of experience here, especially doing walking the walk. Ari has walked the walk, and Stanley's done it as well in France. And it's that knowledge of what's going on in the rest of the country that's really, really important, and where the different people are. I'm happy to coordinate from this side, from the Scottish side, and hopefully be there on the ground soon. Our trip got cancelled just recently, but it's trying to bring all of that together very, very quickly. So perhaps actually sharing all the emails of everybody on this call and coordinating a response. I'm happy to try and coordinate the people who've got something to add and to contribute in terms of the expertise for the power supplies. It's a longer term thing, but we have to sort this out for the future. And as I said in my email, sorting out the oxygen isn't just about COVID. It's about trauma care, it's about malaria care, obstetric care. Every single hospital, health centre, rural hospital lacks oxygen on a regular basis pre-COVID. If we can sort this out in the longer term, as well as doing what we're doing, it's a huge gain, a huge hit for Malawi. If we then look at the short term, which has been discussed, there is only one way of doing the short term, and it's multi-pronged, but some of them are going to be quicker and easier to deploy than others. And Douglas and Stanley will know, because of the work on the ground and the connections, and I think Rachel as well, who needs what that can be deployed quickly. You know, there is an infrastructure for transport from some of the NGOs that would be able to help, and I'm sure Rachel knows them and some of the other people on this call, but we need to coordinate it. Who needs what? What's the quickest way in? As I said, the quickest way in at the moment is refurbished functioning oxygen concentrators with the kit that goes with them, possibly a smaller generator. Unfortunately, that's not the long-term solution. I think solar is a long-term solution, as Ari and others have shown. And think about it, what we need to do in the next 2 to 3 weeks. Where can we get the money? Who's got the money to do the first tranche? Now, Mr. Osmond might be the person that can provide some of that, and others who may be willing to step forward. We can do an appeal to the SNP readership and diaspora, so to speak, and see if anybody's willing to put the money where they can. But I think in the short term, we know that we can get Malawi oxygen concentrators quickly. We can repair them. Douglas and I are involved in some work actually training people to do this maintenance work. But it's a course. It takes time. The equipment and the consumables are a problem, as has been mentioned before. So that's in the longer term. That's, I think, a medium term, getting repairs of what we've got out there. So yeah.
Yeah. Can I jump in, please? Is that okay? Sorry. Hello.
Just 1 minute, if that's okay, Edith, and then 1 minute from John Chalice, who hasn't spoken yet, and then I'm gonna wrap it up and suggest way forward. Edith, over to you.
Okay, thank you. Sorry, just to introduce myself, I'm wearing 2 hats here. I'm working closely with Stanley on the international fundraising side, but along with this as well, I'm mobilizing the diaspora resources, i.e. technical and the financial aspect, to make sure that we are contributing towards a joint coherent strategy addressing the COVID situation in Malawi. Now, on the back of what Alberto has just highlighted, we currently have a challenge that there is so much information coming from the ground that it's even tricky to identify exactly who is doing what and what is required. So yesterday I had a meeting with my haircuts, one of the leading healthy charities, which is registered in the UK but operating in Malawi. And we explored an option of having maybe a portal, like a dashboard, where we can get all these hospitals or the people on the ground to update what their needs are, so that whoever is in the diaspora or in the international scene can actually see where the requirements are and what is it that they can do to support and to help. So if it's okay, Alberto, I will contact you probably after the meeting to see if we can move this forward, because that's an area that we really, really need to address if we're gonna ensure that this is a successful initiative as well.
No, that sounds very useful, getting that live, accurate information. I'm going to turn to John Chalice for a final minute. Before I do, a comment was made about one of the most useful things we could do is just sharing people's contact details. And there's all sorts of rules in the UK about how you can and can't do that. I'm happy to sail close to the wind. What I would say is, if you do not want your email address shared with this group and only this group on this call, please can you send me a direct message now saying, please don't share my email address. So please opt out if you don't want your email address shared. So send me a direct message through the chat box or send me an email saying I don't want my email address shared. Otherwise we will. John Chalice, over to you.
Good morning, can you hear me?
Yes.
Yes, well, first of all, I was in Malawi a few years ago and done quite a lot of work at the mission hospitals in the north. And at Ekwindeni, I did a training course on oxygen concentrators particularly, and supplied them with the necessary equipment to not only repair and maintain the equipment there, but also to test the equipment that it was actually producing oxygen. I went around to some hospitals and found that actually with the test equipment, their oxygen concentrators were not producing oxygen at all. They were just producing air. So that was quite alarming, but you need not only to service them with the filters, et cetera, you need to have the test equipment, which is available to be able to confirm that they are actually producing oxygen at whatever level it is. That's one thing I wanted to quickly say. And secondly, most of the mission hospitals that I'm aware of have generators, quite good generators, which have been installed over the last few years. There's always the problem of fuel. Who's going to pay for fuel? There's no fuel. And also the servicing of those that equipment. I've spent time putting filters into and all the rest of it, but there needs to be much more seriousness done on that. But finally, the thing which tends to break down is when you have lightning strikes, it breaks down all the control mechanism of the generators. So if you have an automatic switchover, that tends to get cracked out pretty quickly, and it's an expensive item to replace. So the thing about generators is a warning that you have to have a manual backup that people can go and switch it on if they have an automatic thing. But if you need an automatic thing, they tend to break down because of the lightning strikes. Thank you.
Thank you, John. That's really, really, really useful. I'm going to draw threads together with an eye to the time on this conversation. Firstly, thank you very much for everyone's time who's come and taken part and shared their experience. I'm sorry if anyone's been cut short or hasn't had the opportunity to speak as they would have liked. Thank you particularly to those in Malawi who are working operationally against the COVID crisis. We appreciate your time. I suggest that one of the main things that we've heard in this call is that there is real value in the coordination of effort and the sharing of information and intelligence. I think we've agreed that it's important that we're not just reinventing the wheel, starting our own initiatives, but looking to support what's there as informed manner as possible, and looking at what are those potentially easier wins as far as rehabilitating kit that's already in the country. So what I can commit to do is that the Scotland-Malawi partnership will, as long as it's useful to this group, these stakeholders, will continue to facilitate these meetings. I'm going to invite. I think Alberto was volunteering himself there, and I think we're all impressed with his insight and strategic thinking to this conversation. So Alberto, I will pick up with you in the next 24 hours and we'll agree sort of operationally what we want to do next. I'm very keen to work extremely closely with Stanley, and I want to really underline this point that we are not looking to reinvent what's happening. And Stanley, we hear you loud and clear that you are working extremely effectively on precisely these issues. My first priority is how do we support those existing initiatives, including yours? And I'm keen to tap into Dr. Lungu's expertise, particularly in the north. I think we've all identified the geographies of the north as real priority areas, particularly up in Karonga and Chitipa as well. So I'll create an additional webpage on the website in the next couple of days or so, specifically looking at the oxygen supply question. I think what we want to do is raise awareness and build a sort of business case to potential prospective funders on this issue, to say, look, this is really important, this is extremely urgent, and there needs to be action, and we can start working on that straight away, even while we are working out sort of internally amongst ourselves what that action looks like. So we'll continue the coordination, we'll create a web page, we'll look to share as many of the contributions that we've had from this call. We'll share the email addresses that we've had, and Alberto and I will work together in the next day or two to think operationally what's the next step. And certainly by the end of this week, we'll be back in contact with you with a proposal of the next step. I think a key thing is sharing what other people are already doing, and that'll be our first priority on that web page. So please expect to get further emails from Alberto and myself asking, can you give me 400 words on what you're doing at the moment? And keeping that updated will be really, really key. I'm going to end the meeting now, but I will save the chat log and I will share a recording of this meeting with those who are on the meeting and a copy of the chat log. If you've had any private messages, you need to save those yourself. I can't save those and I can't share those. So if anyone's private messaged you, their email address, now's the time to press save. But otherwise, let me end by just saying once again, thank you very much for all the contributions. I recognize the seriousness of the situation in Malawi, and I can only offer our earnest commitment from the Scotland-Malawi partnership. We'll do everything we can within our very modest capacity to support Malawi at this difficult time. So thank you very much, everyone, once again. And if there's any thoughts or ideas that you have, what hasn't been covered and what we could do, please send an email to me, and Alberto and I will work together in the next 48 hours or so to come back with next steps. So thank you very much, one and all.